And this is where I'm going to welcome my friend, maybe, my colleague, my mentor, and also a member of IBD Horizons, Dr. Scott Lee. Dr. Lee practices at the University of Washington in Seattle.
That's it. Get away. Get away. Okay. Hope everyone is awake. So a couple things. Anita likes to criticize things the day before. So she said, why did you have to put small molecules, i.e. pills? And I said, well, I wasn't sure the whole audience, mostly her, would know what non-biologic therapies are. So, we're moving into an era where we came from all biologics, and now we're starting to see a wave, and Brian is going to go over what that wave is coming. We still have a few small molecules that are around, right? And so just to frame the conversation, monoclonal antibodies, obviously we know what those are biologics. They're really specific, which limits their off-targeting, which limits their side effects. But there's immunogenicity. They're always parenteral administration at this current time. Small molecules, on the other hand, when we'll go over this, and we've learned from the past that they do have off-targeting and they can have some long-term consequences that we don't see with the biologics. But they usually are cheaper to make. They're oral molecules, right? So no injection, no infusion. And interruption is usually, we think, acceptable. Meaning, with a biologic, if you interrupt, you get antibodies, you're done there. What happened to my disclosures, by the way? So a few disclaimers as we move on. If I insult anyone in the audience, I apologize, except for my colleagues. They deserve it. I just realized Miguel is giving a talk after this, and I don't know if Miguel remembers this. We were in San Francisco once at a program, and Scott Plevy got up. I don't know if you guys know Scott Plevy, and he just kind of abused me quite a bit. So I thought Miguel was a nice guy, and this is a preemptive strike. So Miguel comes up to me and goes, hey, are you okay? Do you ever feel bad what Scott Plevy said? I said, what? I don't. Plevy's sort of an idiot, so that's okay. What I realized is Miguel was taking the opportunity to wonder how far he could go, because every other time I've been in a session with him, I just get roasted. So Miguel, I'm aware of what you're going to do. So this is our laundry list of available small molecules, right? So we know we have 5 ASAs, and I have 30 slides. 20 of them are just for your reference. So we have 5 ASAs, we have steroids, we have thiopurine, azathioprine, 6-mercaptopurine, methotrexate, then we have the calcium urine inhibitors, cyclosporine, tacrolimus, mycophenolate, and then we have JAK inhibition now. So the top of the list, this again is for your reference. You guys know this. I apologize that there are some brand names in here, but it's just to show the differences in the mesalamines where they're released. Hopefully this is old news to you. We know that we have multiple 5-ASA compounds. There are multiple formulations. I can't really figure out if one is better than the other. As far as I can tell, they're pretty much equivalent efficacy. They are first line. I believe we're still in a step world in UC that we should use them for mild to moderate UC. I'm not so sure about severe. And then basically choose the one that's most cost effective for the patient. That's the way it works. I don't personally believe this works for anything other than the mildest Crohn's colitis in a Crohn's patient. If you have ileocolonic or moderate colonic disease, I don't believe this works. We can have that discussion further. Steroids, we all know what steroids are, right? Prednisone, and this is historically what we see, and I think this is, a real slice of what you would see in your practice, because this is from Olmsted County, it's not the Mayo Clinic, and so this is a community group, right? They're highly effective initially, but you can see that, for UC, 1/3 of the patients end up being steroid dependent and 1/3 end up with a colectomy. We also know that the long-term side effects are not worth it. This is Crohn's disease, right? In Olmsted County, same thing. So you start steroids, majority of people feel great, but at 1 year, 1/3 are steroid dependent, 1/3 went through surgery again. And we're not even talking about the long-term risk of steroids. So they do come in multiple forms, right? Budesonide EC, budesonide ER, so ileo release and colonic release. And they do have a lot less side effects than prednisone. But in my experience, if you wait long enough on these drugs, they turn into prednisone, meaning you'll start getting the adrenal insufficiency, the bone loss, et cetera. So you can choose based on disease location, right? Ileal disease, you would choose budesonide EC, colonic disease, ER. But again, they have no role in long-term therapy. So azathioprine, hopefully most of you have gotten the memo that I think the IBD world has really moved away from long-term azathioprine. Again, this is just the older study for your reference, and in Crohn's, right, this is the old Candy trial from 1995. But the reality is, while azathioprine used to be a mainstay, we believe it's a steroid-sparing agent. It's hard to show that it's better than placebo after you induce patients with steroids. But again, long-term risk, lymphoma, skin cancer, cervical cancer. So we have really gone away from more than 12 to 24 months of using this, because that's when malignancy rates start to go up. In combination with TNF therapy, depending on where you live and what you believe in, some people do not want to use azathioprine even in short-term combination because of the risk of Epstein-Barr virus. But they do, we know, right, from SONIC, it increases efficacy, reduces antibody rates, and increases biologic drug level by decreasing clearance. So that's a good thing. But again, we should not probably be using this except in a few special cases as a long-term therapy. Methotrexate, this is Brian's trial from, 20 years ago now, blast from the past. So we know methotrexate works. It's a good steroid-sparing agent. But again, this was an era of biologic naive patients, right? So we don't know if you have someone who's failed 5 biologics and then decide to go with monotherapy with methotrexate, what that efficacy would be. I would hazard a guess it would be lower than this. So we know methotrexate as a monotherapy works. We use it a lot in conjunction with anti-TNF therapy for the same reasons we use azathioprine: antibody prevention, increased drug level, and sometimes we wonder if we might get some synergy, especially for joint issues. So methotrexate, again, effective steroid-sparing agent. There was one study I came across while I was reviewing this that showed there was a slight increased risk. Again, this is not in IBD, this is in rheumatoid arthritis, that there was a slight increased risk in skin cancers, but otherwise no other malignancy signal. It's reasonably effective in bio-naive. It's absolute contraindication of pregnant women, right? So for your women in childbearing age, this is not an ideal situation. And again, we're using it mostly in combination with TNF. It might increase efficacy. Again, Brian's COMMIT trial, which was infliximab plus methotrexate versus infliximab alone. It didn't show at the end of 1 year significant primary benefit, but a lot of things, there was a signal in there where CRPs were higher in the monotherapy group, antibody levels were higher, and drug level of infliximab was lower in that group, but it ended at 1 year, so we did not see that separation. But we're using it as kind of our concomitant drug of choice with anti-TNF therapy. With vedolizumab and ustekinumab, we're just going monotherapy. TREAT registry, you guys have seen this 1,000 times. It's about infection, right? So again, we talk about risks, and we have to frame the reference, which is what we're going to get to next, about what is the real risk of our drugs. It's not in isolation. It has to be with regards to disease activity and what our alternatives are. This is cyclosporine. Very briefly, you guys remember this. Again, this is over 20 years old now. If you have a severe hospitalized colitic patient, cyclosporine or tacrolimus can be salvage therapy. But again, calcineurin inhibitors, tacrolimus, and mycophenolate are not long-term disease. They're effective for severe acute disease, more salvage therapy, but they all have clear dose and duration, right? You're looking at the longer you're on it, the higher dose, more infections, renal insufficiency, which can be permanent, neurological side effects, marrow suppression, right? So this, again, is a salvage therapy. So if you've noticed, almost all of our small molecule therapies, with the exception of mesalamine, everything is now, well, it's short-term, azathioprine short-term, these are short-term, steroids short-term, and methotrexate we're not using as a primary, it's really adjunct. Which brings us to really where we're starting to move towards, which is small molecules, pills that we can use as monotherapy or long-term. So JAK inhibition. You guys know about tofacitinib, right? So the pivotal trial basically looked at the standard thing where people are getting open-label induction or placebo, and then they treat straight through, and they get randomized to 10 milligrams BID, 5 milligrams BID, or placebo. And at the end of the day, the question is, who is doing better? So induction, 8 weeks, right? These are mirror image trials, Octave 1, Octave 2. You can see they look very similar. Low placebo rate, moderate, and remission. This is a Mayo remission, not endoscopic. We do know that, again, if you've been exposed to TNF therapy, these are not quite as effective, but they're still effective, right? If you look at the deltas, they're actually about the same, whether you've been on TNF or not. And what happens is your placebo response in those TNF-exposed patients goes way down. So again, tofacitinib is effective as a monotherapy, and as a maintenance therapy, right? So at the end of the year, you've got placebo, 5 milligrams, 10 milligrams BID. And again, because 10 milligrams won in terms of numerical and statistical, did not win in statistical compared to 5 BID, but numerically it was. The guidelines were you can induce with 10, and you should probably go to 5. This is mucosal healing. Again, similar story. You're getting, similar rates at 1 year with 5 BID and 10 BID. And steroid-free remission, similar again. 10 is numerically superior. But it's really, as the story moved forward, this is what changed, right? So we always knew, hey, there's probably a risk of varicella infections. And you can see this is the adverse events of interest, right? And you can see there's clearly a dose-related phenomenon. So the higher you go on tofa, the more varicella infections one expects to see. And throughout the trials, it was about 5% per year if a patient were on 10 BID, okay? Very few disseminated. Again, there are some genetic differences in ethnicities. But again, the other thing of interest was cardiovascular, right? And you can see one cardiovascular event in 5 BID, one cardiovascular event in 10 BID. So really, it was thought, well, yeah, we see a varicella signal. But in the interim, since we got tofa for UC, there was an ongoing trial, which we can go over a lot, it's an RA trial, right? And again, they were interested in whether 10 BID would be work or be more efficacious long term. So patients were randomized to 10 BID, 5 BID of tofa, or adalimumab. And the special areas of interest were infections, cardiovascular events, and venous thromboembolic events. And you can see that, okay, so interim analysis, there was wait a minute, we're seeing a signal, right? So 19 cases out of 3,884 in the 10 BID versus 3 cases who were receiving adalimumab. So about a 6-fold increase. All-cause death, again, 45 versus 25 in very similar denominators, so about a 2-fold increase. And so the FDA sent out a new black box warning last year and said, hey, you guys got to start counseling patients about this. They also put this very vague, we should put tofacitinib behind anti-TNF therapy for ulcerative colitis therapy. And you should avoid it who have higher risk of thrombosis. We can get into what that means. And then when you're treating the UC patient, try to use the lowest effective dose. Meaning they were saying, yeah, we get it, 10 BID was approved, but we think you should try and reduce that. So the part that is, I think, difficult when you're talking to a patient, right? They say, okay, patients who have a higher risk of thrombosis, you be careful in those. Well, all of our patients with active UC, much less Crohn's, they have a higher risk of thrombotic events, right? We know that, just in and of itself from their disease. And it's upwards, you can look at the literature, it's anywhere from 4 to 12 times normal people. So the question I have is, should we really be avoiding tofa for a possible confounding adverse event in a disease state that's not ours, patients that don't necessarily represent our population, and our population already has a higher thrombotic event? I'm not saying you should just ignore this and never talk to your patient about it, but it's not really giving me pause to continue to use tofa. So the summary on tofa would be, again, there's no comparative efficacy. I think, Miguel is going to go over a lot of comparative efficacy that we have. It's effective for induction and maintenance in UC. I personally think it's likely effective in Crohn's, but it's not going to go for approval. And the things that you have to worry about are varicella infections. We give almost all of our patients, if they've had chickenpox exposure, the Shingrix vaccination. It hurts like hell, so tell your patients about that. Tell them not to plan anything for about 3 to 5 days. And then the second one, tell them to plan anything for 5 to 7 days. So we do talk to them about VT and cardiac, but honestly, the majority of our population are relatively young. They don't have high cholesterol, they don't have diabetes, they don't have several risk factors for cardiac events. Ironically for CHF, this is not contraindicated, right? Because unlike TNF inhibitors, it doesn't appear to bother CHF. It probably does, it works for RA, it probably works for psoriasis, it might work for MS. So again, this is a drug that has multiple, disease states that it can help. It's relatively rapid onset. There is no immunogenicity, so if you interrupt, that's okay, and we can talk a little bit more about that. Pill, obviously, is easier for most patients. Cost, it depends on what you believe cost is really about. So in summary, 5 ASAs are safe. The thing I've run into is they have the highest out-of-pocket cost of just about any drug I use these days. The patients just complain, I can't, it costs me $200-300 a month, and I don't believe they're effective outside of colonic disease. Steroids, sure, they're cheap, they're short-term therapy, but they absolutely should not be a maintenance therapy, and I would suggest that you go back and look at all your patients on steroids and start getting a strategy to get them off of it. Thiopurines, long-term risk, but we probably are using them mostly short-term with anti-TNF therapy and then getting rid of it permanently. Methotrexate, again, it can be a monotherapy, but should not be used in pregnant women. And we're using it mostly in combo with biologics. Cyclosporine, tacrolimus, Cellcept, mycophenolate, this is salvage therapy, and hopefully you're not using a lot of that. And then there's tofacitinib, right? The new risk place it behind TNF, and that's an FDA mandate, so you can't really get a naive patient who has not been on TNF. Counsel the patients regarding shingles, and frankly, just get them to get the vaccine. Use the lowest effective dose. I'll be curious what my colleagues think. I've had a very difficult time dose reducing IBD patients on tofa, meaning they're on 10 BID, they're doing well. Every time I drop the dose, they flare and I have to go right back up to it. So I've really been hesitant to drop the dose, even with the new FDA warnings. And again, I think you have to frame the conversation, right? If someone is really worried about being on tofa, you have to say, well, what's the risk of colectomy? What's the risk of steroids? If you have patients with crossover disease, RA, right? You can use one drug for 2 diseases. I think it works for Crohn's. We can talk about that. And then new JAKs are coming. Thank you.
Thank you, Dr. Lee.